in between 90 to 100% of baseline, and this will decrease hypotension and nausea and vomiting, and also this will optimize neonatal pH. Ephedrine should be used only as a second-line drug in elective cesarean section in relay of phenylephrine when phenylephrine has decreased too much maternal heart rate. And there, in this circumstance, ephedrine is an interesting second-line drug to avoid a too pronounced decrease in maternal heart rate, which correlate with a decrease in maternal cardiac output. But ephedrine total dose should never exceed 15 milligram. I have put on this slide the summary of the international 2018 guidelines. And I thank you for your attention, and I am prepared to take any question. Thank you.
Thank you very much, Professor. Do we have any question from the audience? So thank you so much, Professor. It's very early in the morning over there. Thank you so much.
Yes, it is.
So I'm just wondering about the prophylaxis infusion. Can you tell us, how high we can go and when to start and when to stop the infusion as a prophylaxis?
Yes. Do you hear me well?
Yes.
Okay. If you are using the infusion, it's better, as I mentioned in the lecture, to start with quite a low rate, in between 25 to 50 microgram per minute. And then you adapt this rate according to the blood pressure you are measuring every minute. It's very important to measure the blood pressure every minute because hemodynamic modification during cesarean section under spinal anesthesia can be very quick, very abrupt. And so you really have to adapt every minute the rate of the infusion, or alternatively, as I mentioned in the lecture, to provide prophylactic boluses of phenylephrine.
And in your experience, how high you can go with the drip?
Usually not higher than 100 mics per minute, but in fact, there is no specific rule. The good rate is a rate that is adapted to keep the blood pressure in between 90 to 100% of baseline.
And the other thing that someone asked me before, we saw a lot of severe bradycardia after boluses of phenylephrine. Do you have experience with that? How often do you have to give atropine for it?
Very rarely we use atropine. In fact, you see severe bradycardia usually when you are too late at giving phenylephrine, and at this time, if you are too late, you use huge doses to increase blood pressure, and you can have reflex bradycardia. It is not something that is normally severe, concerning, because it's reflex bradycardia, but sometimes it can be really disturbing. So the good thing is to use very early the boluses, if you are using the boluses technique prophylactically, so that you don't have this severe reflex bradycardia. And if the blood pressure still is not high enough, you may use at this time, as I mentioned, as second line, ephedrine. Ephedrine will increase heart rate, maternal heart rate, and help also keeping blood pressure close to 100% of baseline. You have to be very cautious not using atropine if blood pressure is above 100% of baseline, because if you do that, you will have an increase in cardiac output, and this may induce severe reactive hypertension.
Thank you so much. We have a question from the webinar she just typed in from, I think, from United States. She said she saw the paper about ondansetron that increased efficacy of phenylephrine. Do you have any comment on that?
Yes, I do. There's been a nice meta-analysis performed by one colleague of mine, Michael Heeson, in Switzerland, and his meta-analysis showed that it was indeed effective, but only in obstetric cases. Out of obstetric cases, it is a little bit more controversial. Probably it depends on the timing of administration, and that might be the reason why there are some conflicting results. But overall, the message is that it is likely effective, at least to decrease vasopressor requirements, more than decreasing the frequency of hypotension. So it is something interesting to consider, but don't think that you are going to solve all the problem with ondansetron. The main tool remains the vasopressor, of course.
Thank you. I think we have one more question.
Yes. Since in Thailand, we did not have phenylephrine in the past. So when we face the hypotension in cesarean section, the drug we have in Thailand is norepinephrine. So I would like to know what is the clinical difference between norepinephrine and phenylephrine in terms of pharmacodynamic in this patient. Thank you.
It is a very good question. Thank you for your question. The difference between phenylephrine and norepinephrine are mainly that phenylephrine is a pure alpha agonist, and it has a duration of action that is longer than norepinephrine. Norepinephrine acts as phenylephrine directly. It has a very short onset of action like phenylephrine, but also a shorter duration of action as compared to phenylephrine, and it has a mild additional beta agonist action. So if you are using norepinephrine, it is better to use it by infusion rather than by prophylactic boluses because its duration of action is too short. There are some studies suggesting that there is less bradycardia, which is something sound because it has a small beta agonist action, but there are less studies available on norepinephrine use as compared to phenylephrine, which has a very important background as in the medical literature for now up to 20 years. So a very good safety record for phenylephrine, yet this is not for the moment the case with norepinephrine. It looks to be a promising drug, but with less medical literature available for the moment.
Thank you. We have one more question, Professor.
Yes, in your last, the last slide, take-home message, you said that ephedrine, you said that we shouldn't use above 15 milligrams. Is that right?
Yes, that's right. This is because, as I explained in the lecture, if you are using too much ephedrine, it may promote fetal acidosis because ephedrine in the human species crosses freely the placenta. And if you give too much ephedrine, there will be too much ephedrine on the fetal side. And because ephedrine has mainly a beta agonist action, this will increase the oxygen consumption of the baby. Whereas at the same moment, if you are using ephedrine, it's because there is a decrease in maternal blood pressure and thus a decrease in oxygen supplies to the fetus. So ephedrine is a good drug if you are not using too much, but it may become a bad drug if you use too much total dose of ephedrine.
Yeah. But in our practice in Thailand, do we? I mean, a lot of problem about that. I mean, asking our colleagues, because sometimes we have to use that. I mean, more than 15 milligrams in order to maintain the blood pressure. I'm asking whether it's clinically significant or not to have like acidosis for the neonates, something.
It's a very good question. Thank you. What I can tell you is that, of course, in most randomized control studies, the patients that are included are in good health and the baby are in good health. So most of the time, even when there is severe acidosis due to too much ephedrine use, there is no long-term consequences, and this is not well investigated. But we did a study in my institution in France. I'm going to try to share you the presentation. Here it is. Do you see my slide?
Yes.
Okay, so I'm going to show you this study. This study was performed in the late 80s in France when there was only ephedrine use, no phenylephrine at this time. And we looked at very premature neonates. And it's not a randomized control study, it's a cohort study. And we look at spinal anesthesia as compared to general anesthesia. And we found that with spinal anesthesia, recall what I just said, that at this time we were using only ephedrine and huge doses of ephedrine. We found that there was an increase in overall neonatal death in these very premature and sick babies. Of course, it was not linked only to spinal anesthesia. It was mostly because they were very premature, as you can see, 27 to 32 weeks of gestation. But when using this multivariate analysis, looking at independent factor, we found that spinal anesthesia was likely to increase slightly the death rate of this neonate. So overall, this study suggests that there might be severe consequences for very sick baby if you are using only ephedrine and too high dose of ephedrine. So phenylephrine is a very interesting drug to this regard because when you start using phenylephrine, if you need thereafter ephedrine because the maternal heart rate decreased too low, usually you don't need too much ephedrine. So phenylephrine acts as a sparing drug to ephedrine use, which is very convenient and probably very good for the baby.
Thank you very much, Professor. I think it's our wrap up. Again, we really appreciate your time. Thank you very much, Professor.
It was a pleasure joining you and hope to come back in Thailand when the COVID crisis is over. Thank you very much for your attention.
Bye.
Bye-bye.
Thank you for
Have
your
a nice
attention.
meeting.